Welcome to PQA's Medication Access and Social Determinants of Health Research Symposium. My name is Megha Parikh, and I am PQA's Senior Research Scientist. We are excited to share our current research projects that are examining medication access and SDOH related to medication use. First, I'd like to share more about research at PQA. PQA research advances medication use quality by informing and evaluating quality measures, by exploring and promoting novel solutions in the marketplace, and by addressing gaps in medication use. The types of research we do falls into 4 buckets: medication adherence and safety, medication access and SDOH, pharmacy services, and patient engagement. For this presentation, we will be sharing our current work in medication access and SDOH. PQA is committed to improving care by targeting patients' unmet social needs and evaluating the barriers to accessing medications. When we address unmet social needs and barriers to medication access, we need to think broader than the healthcare system and address the effects of SDOH in our work. I will begin with the definition of SDOH. SDOH is described by the World Health Organization as circumstances in which people are born, grow up, live, work, and age, and can affect a wide range of health functioning and quality of life outcomes and risks. The SDOH factors listed here can affect health outcomes and medication use. As you can see here, some of these factors relate to economic stability, neighborhood and the physical environment, as well as the community and social context. For example, the neighborhood in which you live can affect life expectancy. In Philadelphia, zip codes only 5 miles apart face up to a 20-year difference in life expectancy. Lack of transportation is a barrier to healthcare access and can lead to missed or delayed medication use. Food insecurity, housing instability, and medication costs are all associated with poor medication adherence. When we take a few steps out, we see that policies can promote healthier communities as well as promote economic and social opportunities that can impact medical care and health outcomes. There are a growing number of public health initiatives to address SDOH within and outside of the healthcare system. Outside of the healthcare system, initiatives seek to shape policies and practices in non-health sector ways that promote health and health equity. In our research, PQA identifies the ways in which decisions in multiple sectors affect medication use. PQA research engages diverse partners and stakeholders to work together to advance medication access and SDOH evidence. We are excited to highlight 4 of these partnerships in today's presentation. We will first hear from collaborators that are working to understand the intersection of SDOH and the role of pharmacists and the pharmacy landscape. First, Elham Haidari, PhD student at the University of Texas at Austin, will be presenting her work on how pharmacists and other healthcare stakeholders across the nation are collecting and using SDOH data. We would like to extend a thank you to Pfizer for their support of this project. Second, Leah Moyon, clinical pharmacist and PhD candidate at the University of Arizona College of Pharmacy, will be presenting her work on developing a pharmacy access model and the various factors associated with pharmacy accessibility. We would like to thank Merck for their support of this project. In addition to our SDOH initiatives, PQA has also worked to gain a better understanding of medication access to identify opportunities to improve accessibility. PQA, in partnership with the National Pharmaceutical Council, NPC, set out to develop a framework that characterizes the complexities of medication access. In 2018, PQA and NPC convened a multi-stakeholder roundtable, including health plans, community pharmacies, government agencies, and the patient community, to develop the medication access patient journey, also known as MAPJ. As seen here, this framework includes 7 critical access points or nodes that patients encounter when attempting to access medications. At each node, patients may face several challenges due to social factors that could inhibit their ability to access medication. For example, at the help-seeking node, patients may be unable to attend an appointment with a provider due to transportation barriers, or at the prescription dispensing node may be unable to fill a prescription due to cost. To expand our work on the MAPJ, in 2020, we again collaborated with MPC to issue a request for proposals that explore the impact of SDOH factors on medication access. I will now hand over the presentation to Kimberly Westridge, VP of Health Services Research at MPC, to share about the RFP process and the last two presentations.
We are excited to continue our partnership with PQA to leverage this foundational work to improve healthcare access and quality for patients. Together, we released a request for proposals in the fall of 2019, seeking research projects that built on the MAPJ framework to address barriers to medication access. We received 46 innovative responses, and honestly, it was a real challenge to narrow them down. We awarded funding to researchers at the Johns Hopkins Hospital and the University of Rhode Island. Each of the teams received a grant to study patients' real-world medication access problems. I am delighted that the teams will be sharing their work with you during this session today. From Johns Hopkins, Jessica Mary, a clinical pharmacy specialist in ambulatory care, and Jeremy Epstein, assistant professor of medicine, the principal investigators of the project, will present the impact of a real-time prescription benefit tool on patient access to prescriptions. From Amy Vyas's team at the University of Rhode Island, Stephen Kogut, professor of the College of Pharmacy, and Andrew Descoteaux, a graduate student, will present their work on the impact of patient out-of-pocket costs on adherence to oral anti-cancer medications. Thank you, and we will start with our first presentation from Elham Haydari.
I'm Elham Haydari, and I'm going to present my research entitled Procurement and Use of Social Determinants of Health Data Among Key Healthcare Stakeholders. I would like to acknowledge my co-investigators in this project. This research was a collaborative effort between TechScore, University of Texas at Austin, and PQA. Social determinants of health are non-medical factors that impact our health outcomes. According to World Health Organization, social determinants of health are defined as conditions in which people are born, live, worship, work, and age. Examples of social determinants of health can be economic stability, such as poverty, or education, such as health literacy. Social determinants of health are responsible for structured, avoidable healthcare inequalities. A growing body of evidence shows that health systems need to address social determinants of health as a part of their routine care to improve the patient's health outcomes. However, little is known about facilitators and barriers for healthcare stakeholders to do so. That's why we conducted this research. We had 4 objectives. First, to determine SDOH data collection capabilities of healthcare stakeholders. Second, to identify barriers and facilitators for building these capabilities. Third, to identify high-priority SDOH areas. And lastly, to describe the extent to which SDOH data capture and assessment are involved in short and long-term organizational strategies. This was a cross-sectional prospective survey, including 30 items or 30 questions on Qualtrics framework. For face validity, the survey was sent to 3 PQA members representing community pharmacy, health technology vendor, and health plan. After incorporating their comments, the finalized version of the survey was distributed among 94 PQA members. Data collection was conducted in November and December of 2020, and it included 30 reminder emails. There were 25 eligible responses that gave a response rate of 26.6%. Our participants were diverse. We had a number of pharmacies, health plans, health technology vendors, MTM vendors, pharmacy benefit managers, specialty pharmacy providers, and health plans. The majority of our respondents represented organizations with high coverage. For pharmacy organizations, the majority of them had more than 500 stores. For non-pharmacy organizations, the majority of them covered more than 1 million lives. This map shows how many respondents covered each region of the United States. For example, 12 respondents covered West, South, Central, where I'm at. Notably, 11 organizations had a national coverage across the United States. We measured perceptions about social determinants of health on a scale from 1 to 5, with higher numbers representing higher level of the attribute. The healthcare stakeholders were familiar with social determinants of health, with the average level of familiarity being 4.28 out of 5. Also, the stakeholders thought that it was important to identify and address social determinants of health. They thought that SDOH involvement in organizations' decision-making will increase as time goes by. However, usefulness of social determinants of health data to inform the organizational strategies was not rated as highly yet. Among 25 participants, 14 of them indicated that they do collect and track data for social determinants of health, which makes 56% of the sample. Among them, 5 integrate publicly available risk assessment data as part of their organization's SDOH strategies. Also, 6 link SDOH data with their patients' health outcomes. Among the organizations that collect and track data for SDOH, surveys and electronic medical records were the most commonly used data systems to collect data for SDOH. 11 organizations record SDOH data. 2 of them use Z code as a part of ICD-10 codes, while 9 of them use other data tools, such as their in-house SDOH data tool. The majority of respondents are using their organization's specific tool to collect SDOH data. Currently available standardized SDOH data tools such as Z-code or AHC were underutilized among the stakeholders. Some other currently available SDOH data tools, such as American Academy of Family Physicians tool, was not being utilized among the stakeholders. So, what did we find about SDOH priority areas? Stakeholders are collecting a variety of SDOH indicators that you can see in this slide. The indicators are not mutually exclusive. However, it tells us that health and healthcare indicators and economic stability indicators are the most commonly collected SDOH indicators, followed with neighborhood and built environment, education, social, and community contexts. Lack of a standard data format, lack of time, and lack of technological capabilities were identified as the most common barriers to collect SDOH data. Almost half of stakeholders indicated that they don't have any solution to combat these barriers. On the other hand, value-based payment programs that reward addressing social determinants of health was the most common potential incentive reported. In addition to that, a coding structure or reimbursement mechanism can be another potential incentive for healthcare stakeholders. The COVID-19 pandemic had a very mixed effect on SDOH data collection of healthcare stakeholders. While the majority of stakeholders reported no change due to the pandemic on SDOH data collection, 28% of them made plans to address SDOH. Also, 8% of them accelerated their timeline. On the other hand, 16% of them had to halt SDOH data collection, probably because of some emerging priority due to the pandemic. In the light of the COVID-19 pandemic, most respondents rated their readiness to collect SDOH data as average. In this slide, you can see a comparison between the priority level of SDOH data collection before the pandemic and during the pandemic. On the left, you can see the priority level of SDOH data collection before the pandemic, which was predominantly low priority. During the pandemic, 64% of the stakeholders reported no change in their priority level of SDOH data collection, while 32% of the stakeholders reported higher priority and 4% reported lower priority. Our study had some limitations. First was social desirability bias, which we tried to overcome with identifying the responses. Second was selection bias, which is an inherent problem with convenient sampling. And third was small sample size, which limits the generalizability of the findings of this study. To conclude, around half of healthcare organizations collect and track data for SDOH. Healthcare stakeholders do understand the importance of SDOH data, but for collecting them, they face serious challenges, such as lack of time, lack of budget, and lack of a standard data format. Consensus on a standardized SDOH data collection tool is necessary to advance SDOH data collection. Incentives for SDOH data collection under value-based payment program could promote SDOH data collection. The stakeholders anticipated an increase in the use of SDOH data in the organization's decision-making in the next 3 to 5 years. With this, I want to thank you for your time, and I'm happy to answer your questions during Q&A.
My name is Leah Moyon, and today I'm going to share with you some select findings from my PhD dissertation. The title is Examination of Pharmacy Accessibility in Urban Areas, Development of a Conceptual Model. Disparities in healthcare access among medically underserved populations has been very well investigated, and public health efforts have centered on reducing these disparities. One of the ways they have done this is through federal designations on health profession shortage areas, as well as medically underserved areas, so that we can get better info about the variables that might contribute to decreased healthcare access and decreased healthcare outcomes among these populations. Now, regarding pharmacy accessibility specifically, there hasn't been too much literature around this topic. As part of my dissertation, I did a systematic literature review. And what I found is that the definitions of pharmacy access vary widely across the literature. Also, there have been some studies that have identified a very significant role in some of the social determinants of health that may have an impact on how someone may have access to a pharmacy and then subsequently may have an impact on their health outcomes. In recent years, pharmaceutical care services have expanded to provide essential preventative health care, such as immunization services, and we've really seen that with COVID-19 recently, as well as healthcare screening and assessment, medication therapy management, wellness education, and wellness programs. Yet, despite this expansion in what pharmacists can do out in the community, there hasn't been any real designation to define the areas that might be underserved by pharmacies. So part of my research was to really sort of try and gain or get some of the literature together and find out how we are defining pharmacy access in our literature, so that maybe we can then start to put together some of these ideas on how we can address disparities in care. Part of my theoretical framework was looking at pharmacy access variables specifically. And where I got these pharmacy access variables from was the pharmacy master files I used to map pharmacies across urban areas. And then I verified that they were, in fact, operating pharmacies using pharmacy data that I got online, as well as doing phone surveys to ensure that they were, in fact, operating. And then lastly, I obtained roadway network data from the departments of transportation from the study areas. And all of this put together through GIS mapping, I was able to identify a number of pharmacies, distance to a pharmacy, travel time to a pharmacy, as well as weekly operating hours and the services that were provided by the pharmacies. And altogether, this constructed kind of this pharmacy landscape that gave rise to the supply of, if you will, pharmacies that we have that people could potentially be using. Subsequently, I looked to the literature and to other theoretical frameworks to identify what might be important or relevant factors that could contribute to healthcare access or healthcare outcomes. And I gather all of these together to define the characteristics of the potential users of community pharmacies. So as you can see here, I pulled information from existing frameworks that many of you may be aware of, such as the social determinants of health, Anderson's behavioral model, as well as the Institute of Medicine's model of monitoring access. And then lastly, part of the pharmacy literature that looked specifically at pharmacy deserts had used this existing definition of food deserts. So I went back into the original data on this, and it came from a report to Congress, actually, that used a specific statistical model to identify what food deserts were. So I pulled all of these together and grouped them into these domains. So race and ethnicity, socioeconomic position, vulnerability, meaning the vulnerability of the population, culture variables, residential stability or housing, and then lastly, transportation. And all of these together give rise to what we consider our demand for pharmacies. So in this context of supply and demand, I decided to focus primarily on urban areas. and specifically on urban areas that have a long history of racial and ethnic segregation. The reason for this is because there is quite an abundance of literature out there that shows that residential segregation can have an impact on health outcomes. Now, Chicago and Detroit are historically two of the most racially segregated cities in the nation. This segregation has persisted over time. And some of the original pharmacy research that came out focused on the Chicago area, specifically looking at pharmacy deserts in Chicago's South Side, where there's a predominantly African-American population. So I decided to focus on these two study areas and explore, what would be the variables that could give rise to disparities in pharmacy access specifically. The methodology that I used, first step that I did was to derive pharmacy accessibility scores and categorize pharmacy access based on a low, medium, or high, a relative low, medium, and high based on these accessibility scores that are derived from the pharmacy to population ratios within a given area. And I did this at the census tract level. I looked at what's called the population centroids, which is really the best descriptive measure to determine what is the most concentrated area of a census tract and is most representative of the population there. And then through GIS mapping, I was able to identify distance and travel time thresholds, and then explore the differences based on race and ethnicity. The second part of my analysis was through discriminant analysis, which is the methodology that was originally used in the food desert literature. And through discriminant analysis, which incorporated these accessibility scores and relative levels of pharmacy access, I was able to identify significant characteristics that best differentiate between these levels of access. I was able to look at associations with the classifications, and then lastly, describe low access areas or areas that have low pharmacy access. So I'm going to share with you just part of this because there are so many images and figures and things. So I'm just going to share with you some examples of some of the information I found. And this is just one example of a drive time model where I was able to map through GIS programming. And here you can see I have Chicago on the left, and then I have Detroit on the right. And it's showing you the relative access levels, low, medium, and high, and then differentiated between the white and non-white census tracts. And this 5-minute drive time threshold, specifically I found that there were more non-white census tracts that had low pharmacy access within Chicago. And then within the Detroit metropolitan area, I found that there were more white census tracts that had high pharmacy access. And these were significant findings. Now, I repeated this for each drive time threshold. So I went, 5 minutes, 10 minutes, 20 minutes, 30 minutes, and looked at the differences between them as well. The second part of this was looking at additional pharmacy access metrics. So I looked at the minimum distance it would take for someone to travel to a pharmacy. I looked at median drive time and walk time. And you can see here that there are significant differences between census tracts that are predominantly white and then census tracts that are predominantly non-white. And as you can see, within the Chicago urban area, the census tracts that are predominantly non-white, you could consider them to, have lower pharmacy access. They have to travel a little farther. The drive time might be longer. the walk time is longer, which can be very significant in the winters of Chicago. And then the weekly operating hours were lower. On the Detroit side, the findings were a little bit different. Looking at the larger Detroit metropolitan area, I found that non-white census tracts actually had a little bit better access to pharmacies relative to the white census tracts. But one of, I think, the reasons for this is because there is such segregation in that city that looking in the city center specifically, I found that there were 95% of the census tracts were predominantly non-white. So it may have been a little bit difficult to discern the differences there. Now, looking at specific or significant variables that were associated with pharmacy access levels. Within Chicago, the unemployment rate, walkability, public transit, the percentage of people who were uninsured, the percentage of people who had vehicle access were all important variables in this model through discriminant analysis. And they were found to be significant in differentiating between low, medium, or high pharmacy access. Within Detroit, the picture was a little bit different, though there are some similarities, particularly with walkability. But the differences were, the significant variables were in vacancy rates, home values, and then lastly, that racial composition popped up as a significant variable. Now this is the drive time model. I also constructed the walk time model, which had a little bit, had some similarities, but then of course there were some differences in the Chicago urban area. The crime index actually popped up as a significant variable when it comes to walking to a pharmacy, and as well as households that have vulnerable populations, such as children or elderly in the home. In the Detroit side, for the walk time model, cost of living came up, immigrant status, and then income inequality, which is measured through the Gini index, which has been used across the literature and is regularly used to differentiate between low or high income areas. The most significant variables to the walk time model, however, were immigrant status, the walkability of the area, and then walking to work, meaning how many workers were commuting to work via walking. So factors associated with differentiating between pharmacy access levels varied between the urban areas, though there were a couple of similarities. So pulling all of this together, it's a lot of information, but what I concluded from this was that there are pharmacy landscape differences between urban areas, and it largely has to do with the type of population that is there. So it might not always be easy to generalize pharmacy access models across certain areas. And then looking at distance alone, it may not capture pharmacy access, because what I'm seeing, or what I found, was that there are additional variables such as socio-demographic variables that can contribute to whether or not someone has access to a community pharmacy. Again, you have to consider the urban area community factors, such as crime level, or the walkability of a city. How easy is it for a person to get from one place to another? And then lastly, I found that there were differences in pharmacy access related to race and ethnicity, which is consistent with prior literature on pharmacy access, and that vulnerable populations are less likely to have high pharmacy access or pharmacy access at all. So this kind of not only answers some of my questions, but of course generates a lot of other questions and a lot of other areas for future research. But overall, I think the most important thing is that we should probably be, start to look at these areas and perhaps focus in on what we can do to change the relative levels of access at pharmacy. And at this time, I will take your questions and we can have some discussion. Thank you.
Hello, and thank you for joining us today as we share an overview of our project, Impact of a Real-Time Prescription Benefit Tool on Patient Access. I'm Jessica Mary, a clinical pharmacist in ambulatory care at the Johns Hopkins Hospital. Co-presenting with me today is Dr. Jeremy Epstein, assistant professor at Johns Hopkins School of Medicine. This slide shows the medication access patient journey framework. That was a framework developed by a work group of PQA in 2019. As the red boxes show, cost and insurance are barriers to access in 6 of the 7 nodes, and specifically, prescription cost and prescription insurance are barriers in 4 of these nodes. Many prescribers know the general cost of a prescription, but don't have specific cost information. And we know that from previous literature that there's a direct relationship between the cost of a medication and the likelihood that it will be left at the pharmacy not purchased. Some workarounds to try to improve access to patient prescriptions has been that prescribers will send multiple medications in the same therapeutic category and instruct the patient to pick up the least expensive alternative. This definitely leads to pharmacy workflow waste, but also has an increased risk for danger to the patient if all of the medications are dispensed. Real-time prescription benefit tools have been developed to provide the prescriber with real-time cost information at the point of prescribing. And in 2019, to aid in price transparency, the Trump administration's CMS published its Medicare Advantage Part D drug pricing final rule. And that rule required that by 2021, which we've already passed, all Medicare Part D sponsors would implement an electronic real-time benefit tool that would integrate into at least one of their prescribers' EHRs. There are multiple real-time prescription benefit tools available. Our institution went live with the SureScripts tool in our electronic medical record in July of 2019. This RTBP PB workflow is depicted on this first image. When patients come to their ambulatory appointments, if they have prescription benefits that are contracted with SureScripts, then information is transmitted at the point of prescribing through SureScripts to the PBM, back to SureScripts with a cost estimate that then pops up on the prescriber screen. And this is an example of a pop-up the provider might see. In this case, the prescriber ordered brand name Ambien 10 milligram tablets with a cost estimate of $200. The tool returns estimates from the PBM for alternatives. Generic Zolpidem 30 tablets would be $15 at the local pharmacy or the mail order pharmacy, or alternatively, Izolpiclone could be written for $18 instead. Our project was a retrospective cohort study that sought to evaluate whether addressing the cost components of the MAPJ nodes at the point of prescribing would improve medication access. We also wanted to evaluate the impact of the real-time prescription benefit tool on pharmacy workflows. The goal of the study was to determine the impact of the RTBB tool on access to new prescriptions. We hypothesized that patients whose prescribers used the tool would have improved initial access and durable filling of their medications. We stratified patients into 2 groups based on whether or not the prescriber used the real-time benefit tool at the point of prescribing. First, we wanted to characterize and calculate the types of changes to prescriptions within 30 days or modifications. Secondly, we looked at prescription abandonment and cancellation rates at the pharmacy. And then finally, we looked at the time between an initial prescription and the time the prescription was ready and when it was picked up by the patient. A subgroup analysis was conducted to evaluate if there are any specific classes of medications that the tool would have a higher impact on. We specifically identified prior to the study diabetes agents, antihypertensives, inhalers, and topical corticosteroids. We'll now discuss the methods briefly. Our full data set included all outpatient medication orders from April 1st through September 30th of 2020. These were all orders that were generated at an ambulatory encounter in which the prescription was sent to a Johns Hopkins outpatient pharmacy, because that's where we had access to the prescription data. We then excluded all encounters in which the tool could not have been used, so refill only encounters, my chart messages, which is the email communication. We also excluded orders for DME products, knowing that those would not always be covered by the pharmacy benefit. We excluded orders in which the orders were from providers who had opted out of using the tool. And then we went through a manual refining process of the data. We used a consistent set of rules across the group to identify, to link prescriptions that had been changed. So for instance, insulin A was written and insulin B was written 3 days later. That would not have been caught in our initial data or linked. So we had a manual process to link that information. So our final data set resulted in 10,676 orders. Of those, 5,800 orders were originated without the tool being used, and 4,800 were generated with the tool being, in which the tool was used. We then eliminated the canceled orders, those that were canceled immediately or transferred to another pharmacy. And from there, we have the resultant data, orders that were filled but never picked up and returned to stock within 2 weeks. And then of those orders that were sold, we calculated the time the prescription took to get ready, the time until it was sold, and then for both order returned and order sold, was there any modification to that order? I will now hand it over to my partner, Jeremy Epstein, to discuss our results.
Okay, all right, thank you, Jessica. So I'm gonna start off by talking about the cohort characteristics. And before getting into the details, I want to give you a preview of the table that you'll see to help orient you. The first column indicates the characteristic that's being evaluated, and the next two columns contain the values for the real-time prescription benefit group and then the non-real-time prescription benefit group. And the final value, the final column is the p-value of their comparison. Anything that's red is statistically significant, and you'll see that many of the items here are statistically significant because this isn't a randomized controlled trial. The groups kind of fell where they lay. So you can see that in both groups, the patients are in their 40s, about 60% female, slight majority African-American, and the non-real-time prescription benefit group has around double the number of Hispanic patients. There wasn't any statistical difference between the two cohorts in terms of the medical complexity by one of the metrics, the aggregated diagnosis groups, ADG, although the real-time prescription benefit group does have a higher median total chronic condition count. The commercial insurances, Medicaid and Medicare are the three biggest payers of the prescription drug costs, and the real-time prescription benefit group has a higher percentage of commercial insurance, and the non-real-time prescription benefit group has a higher percentage of the other category, which generally is patients who don't have insurance or are international patients. In terms of the providers who place the medication orders, they're largely physicians, most commonly within internal medicine, although other fields like dermatology and OB-GYN and surgical subspecialties are also well represented. I'm going to do the same preview here for the results table, which I'm going to talk about next. It's really similar to the previous tables, except now there are two p-value columns. The first p-value column is the standard comparison between the two groups, and the second p-value column, the p-value regression model, it's based on the regression model to adjust for the differences in the baseline characteristics, all the characteristics that we just covered. So first, in terms of the modification rate of prescriptions within 30 days, there was not any statistical difference between the two groups. It did not seem that the real-time prescription benefit tool had any impact on this metric. The use of the tool, though, was associated with a statistically significant decrease rate of prescription cancellations from nearly 15% to 9%. And that same pattern held true with prescription abandonment, the decreased rate of 13.5% to 11%. And then the prescriptions were also more quickly prepared and sold. So it was the difference of about 16 some hours and 15.5 hours, and then 30.1 versus 37.1 hours between the two groups. then I have this here just as a total visual that combines all of the data elements from the previous slides into one table. Again, with everything, all the p-value column items in red when they are statistically significant. And so then moving on to the subgroup analysis, like mentioned before, we ran all the previous statistics on these 4 medication subclasses individually and as a group. And then we also did this additional analysis about the time in the pharmacy error queue, and the thought being that these prescription medications might be particularly sensitive to the use of the real-time prescription benefit tool when there are many different topical corticosteroids of the exact same potency and vehicle. And the only thing that matters is which is covered by insurance. Like knowing which one in advance we thought would be particularly meaningful and really highlight differences between the groups. And so I have here one table. It's the time in the pharmacy error queue that is representative of the data that we have for all the other statistics. Essentially, the numbers are too small. You can see here that the real-time prescription benefit group had 29 orders, and then the other group had 30. And so we really were not able to draw any meaningful conclusions about the impact of the tool in these particular medication subgroups or the 4 groups in total. And so to summarize our findings, the real-time prescription benefit tool was associated with multiple beneficial changes, including a decreased rate of prescription abandonment and cancellation of 2.6 and 5.6% respectively. And those are the absolute rates. The relative decrease would be much higher. And then as well as prescriptions being more quickly prepared and sold. The 2 areas where benefit was not shown were with the modification rate and the medication subgroup analysis that I just talked about. To go over some of the strengths of our work here, firstly, since everything was part of a linked system, we were able to track in detail the outcome of each prescription to really drill down on what ultimately happened. And then the metrics here come from a wide range of data. So there's patients, providers, and orders of all different types. And then the results that we have are practical and meaningful, very understandable. In terms of the setting, so I think this one is particularly important. This really was a real world implementation. The notification about this feature going live was very muted. And so the benefits that were shown here that were really significant were not due to some aggressive education or marketing campaign that would be difficult for other places to replicate. To go over some of the limitations, again, this was not a randomized controlled trial. So there's always a possibility for confounding, although we attempted to adjust for that with our analyses, with our regression analyses. The second would be that we had a limited ability to analyze the subgroup medications as described. This was a single health system with an integrated EMR, so results might not be generalizable to other practice environments. The second to last item here is about those who don't have prescription drug coverage. And so those patients would fall into the non-real-time prescription benefit group. And one would think that medications for that group of patients would be more likely to be abandoned, and providers might have to cancel those medications more frequently. But there's some caveats here because our institution will often provide vouchers, essentially covering the entire cost of medications for critical medications that patients can't afford. Then international patients also fall into this group, and they generally have resources for paying for prescription drugs. So it's hard to know exactly the impact of that particular group of patients on the data here. And then the modification analysis. So our 30-day modification statistic was not based on sort of individual note review, chart review, looking at the documented patient and pharmacy and provider interaction and decision-making. It was sort of a rate derived from a reconstructed timeline of medication orders for patients. So some limitations there. And to conclude here, in really straightforward terms, the real-time prescription benefit tool is associated with improved access to medications for patients, a decreased need to cancel medications for providers, and then quicker medication processing and sales for pharmacies. So what does all this mean? Well, I think that this really establishes the benefits of the real-time benefit tools. And so there's a real motivation here to expand them further to other electronic medical records and health systems, prescription benefits managers. Obviously, there's more work to be done. There could be more research focused on the impact on pharmacy finances and operations and the ability of patients to hold on to the medications durably, as well as clinical outcomes. And then understanding the best way to implement these tools at an institution, I think, would be another area to pursue. And want to show here the full list of our study team members and collaborators. The project involved multiple rounds of data extraction and many, many hours of data refinement. And so we are deeply thankful for everybody's contributions here. And we will stop here for questions. Thank you so much for taking the time to learn about our research.
Hello, my name is Stephen Kogut, and along with Andrew Dakota, we will be presenting results of our research project investigating the impact of patient out-of-pocket costs for oral anti-cancer medications on medication adherence. This project is sponsored by the Pharmacy Quality Alliance and the National Pharmaceutical Council in support of research to address barriers that patients face in assessing needed medications. Funding for the project was provided by NPC. The principal investigator for this study is my colleague, Dr. Ami Vyas. Dr. Vyas was unable to be with us today due to a family emergency, but I want to underscore that this is her project, and Andrew and I are grateful to be her collaborators. As we know, in general, patient adherence with prescribed medication is often inadequate, and medication therapy in cancer specifically is associated with barriers that challenge the patient's ability to adhere to the regimen. Attention on the issue of adherence with medication in cancer has been heightened by the trend of therapies for many cancer types, shifting from infusions of chemotherapy to oral therapies managed by the patient. Cancer medications can have a more burdensome side effect profile, but a most formidable barrier to adherence is the high cost of many cancer medications, coupled with the substantial cost sharing built into pharmacy benefit designs. This causes difficulty in affording medication, or so-called financial toxicity. This disproportionately affects Americans at lower levels of income and exacerbates health disparities. This slide presents example patient out-of-pocket costs for cancer medications, showing that in Medicare Part D, patients were responsible for more than $10,000 in cost sharing per year for several oncology medications in 2019. Coinsurance is also an increasingly common feature of pharmacy benefit designs in employer-sponsored insurance. This project was informed by a conceptual framework provided by the World Health Organization, which considers 5 dimensions of medication adherence, as indicated by the circles on this slide. I will explain how each of these dimensions was presented in our study in a few moments. On the left side of the slide, beneath the image of people, is a column of 4 circle patterns. These denote how the barriers to adherence that confront patients are varied, indicated by the different sizes of circles that represent the 5 dimensions of medication adherence conceptualized in the World Health Organization model. This project had 3 aims. First, to assess trends in patient out-of-pocket cost and patient adherence with oral anti-cancer medication. Second, to evaluate the association between out-of-pocket cost and patient non-adherence with oral anti-cancer medication. And 3, to determine if non-adherence is associated with subsequent healthcare utilization. Today, we are presenting the results of the first 2 aims. This was a retrospective observational cohort study of oral cancer medication use during 2010 through 2017, using the Optum de-identified Clinformatics Datamart database. This is a database comprised of administrative health claims for members of a large national managed care company. We included patients who received at least 1 prescription for an oral anti-cancer medication and who had at least 12 months' time of follow-up in the database. We measured adherence using the proportion of days covered approach. Patient out-of-pocket cost was measured as the average per month patient cost share, and adherence was operationally defined as a dichotomous outcome. Predictors of non-adherence were assessed using multivariable logistic regression. The dimensions of adherence that we evaluated are presented here using the World Health Organization framework. Health system factors included the insurance type as commercial or Medicare, and plan type as HMO, PPO, and so forth. Social and economic factors included household income, education level, and if the state had a parity law in place. Therapy-related factors included the medication cost and its dosing schedule, as either once daily or requiring multiple daily doses. Condition-related factors included the cancer type and patient comorbidities. And patient-related factors included patient age, sex, and race and ethnicity. Now I will hand it over to Andrew to share the results.
Thank you, Dr. Kodiak. I will go over the preliminary findings for aims 1 and 2 of our study. Utilizing Optum data from 2010 to 2018, we implemented the following selection criteria. Patients had to have at least one oral anti-cancer prescription claim between July 2010 and December 2017, be 18 years or older at the time of the first fill, which we define as the index date, have no concomitant oral chemotherapy claim on the index date, have a diagnosis code matching the indication of the index medication, be continuously enrolled 6 months prior to and 12 months immediately following the index date, and have non-negative out-of-pocket costs for the index medication. After all of the inclusion and exclusion criteria were applied, we ended up with a little less than 38,000 patients. Next slide. Average monthly out-of-pocket costs were calculated separately for each cancer type. As anticipated, the breast cancer and prostate cancer cohorts had the largest sample sizes, but they also had some of the lowest out-of-pocket costs within the cohort at $165 and $106 respectively. Patients with blood cancer or liver cancer experienced the greatest financial burdens related to their oral medications, spending over $700 per month on average. Next slide. This graph is just a visual representation of the average monthly out-of-pocket costs for each cancer type by the year of the patient's first prescription fill. Costs were adjusted for inflation. Overall, patient out-of-pocket costs were relatively stable throughout the course of the study, with no sort of upward trend, suggesting that this therapeutic class has been represented by high cost burdens for the last decade. Next slide. Medication adherence was measured as the proportion of days covered. Patients needed to have a PDC of 80% or higher to be considered adherent. Here we see the proportion of patients who were adherent to their oral medications for each type of cancer. Patients with brain, stomach, or lung cancer had some of the highest rates of adherence, all of which were over 64%. 3 cancer types, ovarian, colorectal, and liver, all had less than half of their patients adherent to their medications. Next slide. Again, this graph just acts as a visual representation of the average PDC for each cancer type by year. Despite new oral anti-cancer medications being introduced into the population, adherence seemed to stay relatively stable throughout the course of the study. Next. The following tables compare adherent and non-adherent patients across different levels of viral covariates of interest for the overall cohort. All age groups had higher proportions of adherent patients compared to non-adherent patients, though it appears to be higher in patients younger than 65. All race and ethnicity groups had larger proportions of adherent patients compared to those who were non-adherent as well. The highest rate of adherence was observed among Asian patients, followed by those who were white, while the lowest rates were observed among Black patients. Next slide. Within our study, insurance was categorized as commercial, Medicare with low income subsidy, Medicare age 65 plus, and Medicare age less than 65. Among the 4 different insurance groups, commercial insurance had the highest percentage of adherent patients at almost 54%. This is in line with the younger age groups tending to have higher rates of adherence, as was discussed on the last slide. All types of health plans had higher proportions of adherent patients, except for health maintenance organizations, although it was pretty close to being about 50%. HMO plans were most prevalent within the Medicare age 65 plus group though, which could be one possible explanation. Next slide. Socioeconomic characteristics in the study included patients' annual household income and level of education. The number of adults living in the household was also included, as it may be indicative of some level of social support, potentially impacting patients' adherence to their medications. On the whole, it appears that patients with higher income and education levels tended to be more adherent. Additionally, patients living with other people had better adherence than those living alone. Next slide. Multiple clinical and therapy-related covariates were evaluated. Some of the most compelling were concurrent injectable chemotherapy, dosing schedule, and typical dosing. 55% of patients who did not receive injection chemotherapy were determined to adhere to their oral medication, whereas only 46% of patients who did receive injection chemotherapy were adherent. Similar trends were seen in our covariates related to medication dosing, where 55% of patients who took their medication once daily or who had a typical dosing regimen were determined to be adherent. Next slide. Out-of-pocket costs were categorized as the highest quartile of cost versus quartiles 1 through 3. The unadjusted odds of medication non-adherence associated with the highest out-of-pocket costs were calculated separately by cancer type. Across all cancer types, except for breast and prostate, patients with the highest out-of-pocket cost had higher odds of being non-adherent to their oral medications. Next slide. We performed multivariable logistic regression to evaluate the association between patient out-of-pocket cost and medication non-adherence, controlling for our covariates of interest with adjusted odds ratios and 95% confidence intervals reported as a measure of effect. Highest out-of-pocket costs were significantly associated with medication non-adherence in most cancer types. Here we see adjusted odds of 2.89, 2.93, and 3.91 for the blood, lung, and renal cancer cohorts, respectively. Clinical and treatment-related covariates, especially inpatient hospitalization and concomitant use of injection chemotherapy, were important predictors of non-adherence in almost every cancer cohort. For instance, in the blood cancer cohort, the odds of being non-adherent were 3.7 times higher for patients who had at least one inpatient hospitalization stay, while in the renal cancer cohort, the odds of being non-adherent were almost 5 times higher for those who received injection chemotherapy in addition to their oral medications than for those who didn't. Race and ethnicity was significantly associated with higher odds of non-adherence in a couple of the models. However, the findings differ across cancer types. Among patients with blood cancer, those who were Black or Hispanic had higher odds of being non-adherent when compared to patients who were white. On the other hand, within the lung cancer cohort, Asian patients were almost half as likely to be non-adherent than white patients. Next slide. Highest out-of-pocket costs were associated with about 1.7 and 3 times higher odds of non-adherence within the colorectal and ovarian cancer cohorts, respectively, while in the prostate cancer, it seemed to have almost a protective effect with an adjusted odds ratio of 0.84. Again, inpatient hospitalization and concurrent utilization of injection chemotherapy were strong predictors of non-adherence. Next slide. Patients with liver cancer who had the highest out-of-pocket cost had 3 times higher odds of being non-adherent to their oral chemotherapy compared to patients with lower cost. The number of adults in household was significantly associated with non-adherence among patients with brain cancer. Using 3 or more residents, including the patient, as the reference, the odds of non-adherence were over twice as high for patients who lived alone. And now I will hand it back over to Dr. Kogut to close it out.
Thanks, Andrew. So in summary, we did observe that the highest levels of out-of-pocket costs were associated with greater likelihood of non-adherence, controlling for a range of patient therapy-related and other factors. Both out-of-pocket costs and adherence varied by cancer type. Patient costs were highest for liver and blood cancers, while adherence was poorest among patients using medications for colon and liver cancer. Additionally, factors associated with non-adherence included recent receipt of chemotherapy, the oral medications dosing schedule, race and ethnicity, and living alone. Our next steps are to finalize the multivariable analyses for each cancer type and to evaluate the association between adherence and subsequent utilization of healthcare services. We plan future studies to evaluate interventions to promote adherence with oral anti-cancer medications. Thank you, and we'll be glad to entertain any questions that you may have.
Hello, thank you to all of our presenters for the wonderful presentations highlighting the great work that has been completed. We've had some great questions come in throughout the session that we will discuss with our presenters. Please continue to enter your questions in the Q&A box, which can be found on the right hand of your screen. All right, our first question is for the URI team. So you found that higher out-of-pocket spending was associated with non-adherence for all cancer types except breast and prostate cancer. Why do you think that cost was not associated with adherence for these two cancer types?
That's a great question, Asia. I hope you all can hear me very well.
Yes, we
Well,
can.
our study included, the oral anti-cancer medications for breast cancer and prostate cancer. There were majorly the hormonal therapies that have been on the market for quite some time, compared to the other oral anti-cancer medications for other cancer types. So that could be one of the potential reasons why the out-of-pocket costs of oral anti-cancer medications for patients with breast cancer and prostate cancer was lower. In addition, we also found that the threshold costs for quartile 4 that we use to model the association between adherence and out-of-pocket costs for breast cancer and prostate cancer were lower as compared to for the other cancer types. For breast cancer, it was greater than $75. For prostate cancer, it was greater than $15. While for the other cancer types, it ranged from greater than $250 to greater than $1,000. So that can also be one of the reasons why we did not find a significant association between higher out-of-pocket costs and medication adherence for breast cancer and prostate cancer. We also think that, due to the chronic nature of breast cancer and prostate cancer, it's likely that many patients, who have these cancers, have these cancers for several years, and it's likely that they may not be getting intermittent chemo. So it's likely that these patients receive relatively low intensity therapies, which are priced lower than the OAMs or oral anti-cancer medications, indicated for other cancer types.
Okay, thank you so much, Ani. All right, our next question is for the Johns Hopkins team. So Jessica, I'd love to know more about why you all picked the April to October timeframe for your study.
Sure, I'm happy to answer that question. We wanted a time frame that would be not the beginning of the year, knowing that many prescription benefits plans have deductibles that require the patient to meet a certain cost before the copays kick in. So we wanted to avoid any gray area from the deductible, but also knowing that many patients in Medicare Part D plans run the risk of hitting the Medicare coverage gap. We wanted to try to avoid looking at prescriptions too late in the year for that coverage gap. So we resulted in an April to end of September timeframe, kind of that middle of the year, hoping to capture as much of the main plan as possible.
Okay, thank you so much. All right, next we'll move to Leah. So your focus on these urban centers is reasonable. How do you think your methodology or model would differ in a rural or suburban setting?
So I think, so some research has been done in rural areas and suburban areas already. I think the thresholds for distance and time would certainly be different because people have to travel much farther in the rural setting. And I think some of the early research actually used high thresholds like 20 miles as an example, which would not be applicable to an urban center. So the models that I did specifically focused on these urban centers for that reason, because of the difference in travel distance between where someone may live and the pharmacy they may go to.
That's really helpful to hear. Thank you. All right, next we'll move to Elham to hear more about the SDOH survey. So we know that value-based programs were listed as a facilitator to implementing SDOH data collection and use. Which groups out of pharmacies, health plans, or physicians do you think are best positioned to capture these data?
Yeah, thanks, Asia. That's a great question. I'm happy to answer. So, respect to value-based program, many different stakeholders and they can contribute, but one healthcare stakeholder that can have a critical role, maybe health plans. Health plans are really important, and also pharmacies can have a critical role in supporting health plans for addressing challenges.
Great. Thank you, Elham. Are you still there? Okay,
Yes.
good. Okay, good. All right, the sound was going out just a bit. Thank you. All right, so next we have an audience question for either Stephen or Andrew. So when Part D was created, the cost sharing in the catastrophic phase may have seemed reasonable. With more high-cost specialty medications covered under the drug benefit, is it time for CMS to reevaluate the catastrophic coverage?
Can I just answer by saying yes? I think, that's a really important question. Certainly the manufacturers have been in the crosshairs, and, the pharmacy benefit design is also, part of the issue for sure. Even in the catastrophic, the 5% cost sharing in the catastrophic tier is one thing, is 25% until then. And of course, we've seen co-insurance and employer-sponsored plans as well. So, certainly, at least in my view, it seems counterintuitive to, provide more affordable access to medical care, but not the medication. So that's how I'd answer that.
Yeah.
Thanks.
Thank you. Appreciate your candor there. Great. So to Jessica and Jeremy, and perhaps Jeremy, you can take this one. Were there differences in change in prescriptions for modification, cancellation, or abandonment rates when you looked at the drug's formulary tiers? So were there differences across, the lower or higher drug tiers?
I can answer that one. We didn't. That wasn't one. That part wasn't analyzed. We didn't look at it by drug tier. Although certainly, I would presume that those that were cheaper and more that were on the lowest tier would be much more quickly filled, more easily accessible. But that type of analysis wasn't part of our study.
So Leah, when we think about pharmacy accessibility, how important is the patient perspective to your work, and what would be an important way or a way to incorporate that into this research?
That's a really great question. There's probably a lot more that goes into why somebody chooses a pharmacy that they choose. I think for future research, it certainly would be important to get that perspective. I think one way to do that would maybe be survey research, or maybe even better, like focus groups where, researchers can talk to the community members and identify some of those elements that make, a pharmacy, make them more likely to visit one pharmacy over the other. With that, in addition, I think knowing the coverage of a patient, whether they're receiving public coverage or private insurance coverage, is also important. And we could certainly get that information by doing some focus groups or survey research.
Great, thank you. I think qualitative definitely adds an extra layer of information to those findings. Great. All right, so our next question is for Elham. So in the survey question about barriers to SDOH collection, the two most common barriers listed were a lack of standard data format and a lack of time to collect data. What steps do you think we can take to overcome these barriers?
Yeah, thanks. Good question. I think it's very important at this point to develop a standard data format to collect data for social determinants of health. Also, it's really important to dedicate time and budget for this cause. And simultaneously, it's really important to make sure that the different stakeholders access technological capability to collect data for social determinants of health. Also, it's important to make sure that different stakeholders, including providers or even people in administration, receive enough training and they understand social determinants of health and the related definitions. So I think these are the main steps that we need to take for addressing these challenges.
I appreciate that. Thank you, Elham. So our next question is to the URI team. So it's from the audience. Thank you for your excellent research. Can you please speak to how interventions may be targeted to those patients living alone? That seems like a very difficult population for outreach.
You know, that's a really great question. Let me pause and see if Ami or Andrew have a perspective on that.
Hi, can you all hear me?
Yes?
Okay, great. One way that we think that our data can be helpful to develop the interventions is that, if the patients or the practitioners identify that, that patients are not adherent to oral anti-cancer medications, then they can perhaps develop some strategies to overcome the barriers that patients may face. So some of the ways through which these barriers can be overcome is by the use of some sort of reminder systems to remind the patients to take their medications on time, or any other strategies to overcome the barriers that can help patients to pay for their medications or to improve the access to the medications.
Thanks, Ami. Maybe I just add to that some potential interventions to explore might be to address transportation issues if patients are having challenges getting to the pharmacy or to the clinic, well, maybe that's just another idea. I'll leave it at that.
Thank you so much for sharing. Okay. Next, back to Hopkins. So Jessica, actually not someone, we have a name actually on this one. It wasn't an anonymous question. So Michelle Vu was wondering, what considerations for potentially high collinearity of SDOH variables did you make in constructing your models?
Can you repeat the first part of the question? What considerations for
potentially high collinearity of SDOH variables did you make in constructing your models?
So thank you for the question, Michelle, and thank you for listening in. We really wanted to focus on the areas of the patient prescription cycle that maybe the patient would not have as much control of. So the patient wants to, is doing their part by eating healthfully, by not imbibing in alcohol and trying to do everything they can, but the cost of the prescription is the biggest barrier, maybe pride. And so we really wanted to focus on where the health system can help the patient and that the patient is maybe unable to assist. So the prescription, allowing the providers to have an idea of what the prescription is, the patient to be informed at the point of prescribing so that there is a conversation and communication and the patient becomes part of that team and making the decision before leaving the prescriber's office for the prescription.
And then maybe just to add to that, if I could, we didn't have access to other like discrete variables for social determinants of health, sort of beyond more standard demographics, and then markers of medical complexity, and then the payer category, which certainly could reflect some underlying social determinants of health.
Thank you for that. Great. So Leah, what do you think are some specific future research implications of your work?
Well, I think that one of the areas in which I had limitations for my research was looking at the public transit component, because adding in the public transit part of the road network is very, very complicated. And I think it's important to consider, especially in urban centers like Chicago or Detroit, And again, especially when the two different cities may differ in the level of public transportation that they provide to the community. So I think that would be one of the first places that we would need to do some more research. And then secondly, I think looking at, which I mentioned before in answering a previous question, is the prescription drug coverage and how that may play into pharmacy accessibility. It may not be that patients are able to go to the closest pharmacy because they are not able to fill prescriptions that are covered by the prescription plan that they have. So I think those would be the first two areas that future research should definitely look.
Thank you. Great. Another question for Elham. So in your study, you found that most organizations reported that there was no change in SDOH data collection priority, whereas some rated it a lower priority due to COVID-19. Why do you think that is? Do you feel that some priority levels may vary based off the organization type, or is there something else at play?
Yes, the short answer is I think it depends on the type of healthcare stakeholders that was the respondent. So it's worthwhile to mention that we had the respondents that indicated they had to halt their SDOH attempts due to the pandemic. And on the other hand, we had participants that accelerated their timeline for addressing SDOH data or for collecting SDOH data. Or at the same time, we had participants who started making plans for social determinants of health needs of their patients and their enrollees. So that's why this varying effect of the pandemic showed up in the result of our survey. And I think, yes, it's definitely depending on the type of organization, because different types of organization respond differently to the COVID-19 pandemic based on their agenda, based on their use.
Absolutely, and I agree, context matters. So I think as organizations move forward, that is definitely something to keep in mind for any SDOH initiatives. All right, so our final question is for the URI team. So what implications does your research have for pharmacists and other practitioners who provide care to patients with cancer?
That's a nice question, Asia. So our research provides important data that can be helpful to the pharmacists and the other practitioners who take care of the cancer patients. Our study indicates that there are several factors, including out-of-pocket costs and other factors that can contribute to medication non-adherence among cancer patients. And if the pharmacists and the practitioners identify what those factors are, then they can develop some recommendations, to improve their patients' medication taking behaviors. And there are different ways through which they can improve their patients' medication taking behaviors by managing the side effects, if side effects is causing medication non-adherence, or strategies to overcome the barriers to pay for patients' medication, or even to improve the access to patients' medication. There are also a bunch of different programs, that have been developed that focuses on medication costs. And our data definitely validates that those programs are required. And, we need to intensify our efforts to work on those programs, that focuses on medication costs in cancer patients. So our data can be, used by, folks who are working on these programs.
Thank you so much, Ami. Great. Well, thank you so much to all of our researchers for the great discussion today. And thank you to our audience for tuning in. Next up, we have the poster session. 20 posters surrounding medication use quality are being presented. To visit our poster sessions, navigate to the All Sessions tab. to view all of those, to visit all of the sessions. They are available for the next hour, and you're allowed to navigate between a variety of presenters during that time. You can add a poster to your schedule in order to view a PDF of a poster, and that will be found below the poster abstracts. You can select join a session to join a Zoom session with the presenter to discuss their work. We hope you enjoy the poster session, and thank you again for joining us today.